Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more. In our podcast today, we will sit down with Dr. Jeff Pettey from the University of Utah and talk about sustainability, global ophthalmology, and what you could be doing in your practice and your state.
Dr. Jeff Pettey is an associate professor of ophthalmology at the University of Utah Department of Ophthalmology and also serves as the vice chair of clinical affairs there. Dr. Pettey specializes in complex cataract surgery and anterior segment surgery. He is a leader in health policy, global ophthalmology, and sustainability. Welcome, Dr. Jeff Pettey.
Thank you. Thank you, Andrea. Thank you.
We're so happy to have you here. You're such a leader. You're a dear friend. I'm so excited to talk with you. And we were just kind of chatting offline. You and Eric both don't know each other very well, but I feel like you are cut from the same cloth. You're both true philanthropists and humanitarians at heart who have dedicated so much of your career to global work. And we've had the honor of having some really huge global leaders on the podcast, and we've talked about global a lot. It's a passion for all of us. And so you're such a leader in that space, and your global work has kind of led you to being involved in sustainability, which is something that I think we're all very excited about. It's an opportunity for ophthalmology to be on the forefront of initiatives that help our world, help our patients. And so I'd love to hear about just kind of your career journey, how you found yourself in a position where sustainability came to your attention, because it's really a new initiative for us. So would you take us through what that's looked like for you and how you got involved in sustainability in ophthalmology?
Yeah, thank you, Eric, and thank you, Andrea, for having me. It's an honor. You know, my journey to sustainability is really a journey to eye health and global eye health. We all see in our training programs in our backyards the challenges of our U.S. healthcare system, or if you're in another country, the healthcare system which you have. Each system has pros and cons. Our healthcare system in the United States happens to leave a large section of our patients with less care or without care. And so as we see that in our own backyard, of course, as you travel to other places, you can see the same thing. And not everyone in the world has the same access to eye health and eye care that we are afforded here in our institutions and our practices. And as we look at the patients who are going to be disproportionately affected by climate change, these are the patients who tend to be unfunded. There's actually a metric within the United States, and they look at it's the social vulnerability index. And again, if there was a natural disaster, how likely is it that you'd be able to have resources, to have help, to have health care? And that social vulnerability index overlays with where patients don't have care, where underserved patients are, and that also overlays throughout the world. So again, climate change, something that is upon us, that will affect patients with low resources. That will affect patients, these large areas of the world, which will have large migrations of people. Eye health, glaucoma, cataract, those are going to be, not secondary, not tertiary, but even quaternary concerns of people as they're just migrating and looking for food. And so the story of sustainability in ophthalmology is a story of eye health and its effects on patients worldwide.
I love that.
I think it's fascinating how I understand that passion and that interest of yours and how it's brought in that not just awareness, but active engagement and even leadership in sustainability within your role as an ophthalmologist at home and nationally. Share with me and our listeners, as an ophthalmologist serving and experiencing global ophthalmology opportunities, here at home, what have you done to get involved in advocacy, leadership? I understand your role at the AAO is a meaningful part of your life. Help us or understand those pieces to your practice and leadership here in the United States.
Yeah, I chair the American Academy of Ophthalmology Sustainability Committee. And in that role, my job is to raise awareness about sustainability for its members and ensure that we are communicating the importance of sustainability throughout all of the things that the Academy does. One, of course, is education. We've recently added language to the basic science series and the basic principles of ophthalmic surgery around sustainability and a focus on using less and creating less waste in the operating room. Of course, the Academy has a significant advocacy arm as well. And that advocacy arm is really where we make the impact. First of all, we need everyone. You can be private practice, hospital-based, VA, doesn't matter. Every one of us can see opportunities to use less, and particularly in the operating room. Healthcare sector generates the second most amount of waste behind the food industry in the United States. 70% of the waste that is produced is simply from the manufacture of what we are using in the operating room. And ophthalmology has a unique contribution here, and a unique, not in a great way, but just a way that is a consequence of us doing lots of surgery. All of our patients have two eyes. So many of our procedures, cataract surgery in particular, we're doing two surgeries. And we all have seen and carried the giant garbage bags for a single case out and seen those thrown away, case after case after case. We currently do around 20 million cataract surgeries in the world. It's estimated that we'll be doing 50 million cataract surgeries by 2050. And if we continue to produce the amount of waste that we're producing, we really are approaching something that's unsustainable. And that's just ophthalmology's contribution. So with advocacy, our ability to change regulations, ensure that patients are protected and safe while using less, being able perhaps to reuse certain instruments that we've never thought of before, reusing phaco-packs in the case of cataract surgery, reusing gowns. We know from the Airvent healthcare system, their infection rates are equally as low as any published infection rate in the United States. And they have a model per cataract surgery that produces 20 times less waste for a single cataract surgery than we do here in the United States. And so there's somewhere we can meet in the middle, but advocacy and changing rules, regulations, that's really where we're going to have some of our biggest impacts.
I was going to say, I love hearing that piece, because I think all of us step into the OR and understand how a cataract case, or even a chalazion sometimes, or whatever you might be addressing, is treated no differently in our room than the next room where they're doing a liver transplant. I mean, just whether it's the operative setup, and certain aspects of it in quality are important, and then there's other aspects that's just assumed we do and not always needed. Before we get to advocacy, share with us your thoughts, like when you step into an OR or you step into your clinic, what are things tangibly people should have on their radar that they could do in their clinic today without starting a quality project, or without really pushing back on administrative decisions that are made in a broader context for the OR or clinic? But what are the low-hanging fruits before that next step that you would like people to think about walking into clinic or the OR that are quick fixes or quick decisions that would help in sustainability efforts?
Yeah, this is a perfect time to introduce iSustain. So iSustain is a multi-specialty movement. I should say multi-subspecialty movement. This is among David Chang's legacies to ophthalmology. And this is, there are three primary partners in iSustain. That's ASCRS, American Society of Cataract Refractive Surgery, ESCRS, European, and then the Academy. And these three are the kind of funding entities. These are the entities that have really got this iSustain movement going. There's been a magnification of impact through the solicitation of multinational societies throughout the world. I couldn't quote you the exact number because it's growing all the time, but I do know it's more than 70 societies from around the world that have now joined iSustain. And when you go to the iSustain website, isustain.org, you'll see this is the central hub for everything in terms of sustainability in ophthalmology. If you're looking for journal articles, you're looking for talks, you're looking for other resources and ideas, this is the place to go. So if you're just hearing about this, you haven't really thought about it, or you're well along in your journey, that's where you want to go. There's an app available as well. And when you go there, the first thing you'll see is, again, resources page, but you'll see something called the I Sustain Pledge. The pledge is something that any entity can adopt. And the pledge simply says, I will do the following that will help with sustainability, educate my staff to have increased awareness. And then it goes step by step, things that you can do. And again, the pledge is simply, we're going to do this within our institution. So as an academic center, you can do this. As an individual practice, you'll see the wording is a little bit written for kind of an ASC audience or a surgical center audience, because so much of the impact that we can have will start there. But if you right now go to that website, educate yourself, sign up and take the pledge, it's got a series of ideas, simple things that you can do with your staff right now. Reevaluate your surgical packs. When was the last time that you did that? What are you not using consistently that you could have peel packed? That alone can have a significant impact just because of the number of surgeries that we're doing. And again, many other ideas that you'll find there that are simple, practical, and will have a significant impact as we all do them together.
I love that you have those resources for everyone. Jeff, I'm just curious how you found yourself in this position. Is it because you were seeing how other people were operating overseas? You were at Aravind and seeing their different practices and you wanted to bring it back? Like, how did you become the person in this space?
You're spot on, Andrea. It very much came from working throughout the world at world-class eye centers, an eye center that any of us would be happy to have their surgery done. And simply you see the efficiency that they're able to operate at, the high quality they're able to deliver, the outcomes that they're able to deliver. And again, for an entire day of surgery, they would take a single bag out of the operating room, again, 20 times less. In fact, as you look at the amount of the carbon footprint of cataract surgery, it's 7 times the carbon footprint to do a cataract surgery in the United States that is to do somewhere like at an LV Prasad and Aravind. And again, there are many, many others. Because Arvind's published so much, you'll certainly hear a focus on them and a discussion on them. But that's, again, where it came from for me is I work in Tanzania, and there's roughly 1 ophthalmologist per million people. And in front of you, it's laid bare how lack of access to eye care and eye health affects communities, affects a country, and affects individuals. And when I really considered, again, global warming, climate change, my ability to move north to Montana if I wanted to and take a different job, it's not really a big issue for me. Perhaps, again, because we have resources, we've got these safety nets here. But the majority of people in the world don't have that level of mobility, of course. They don't have that safety net, that social vulnerability idea. And so this becomes, equally as important as our improvements and discovery in finding new cures, finding better ways to treat glaucoma. That's only as helpful as it's only helpful when we can actually deliver the care to those people and those individuals. Again, and in a world where climate change is disrupting lives, where climate change is causing mass migration, eye care, glaucoma drops, etc., that's not going to be a high priority for these people.
So I just recently was able to actually see and learn about some of the social vulnerability you're talking about, where you look at the maps of where natural disasters occur and where our vulnerable patient populations are, and they completely overlap. And it really blew my mind. I didn't understand this until I was able to see it. And I think it's happening worldwide, like you said. And so there's these patient populations that are extremely vulnerable in so many different ways and then don't have the reserve also, like you mentioned.
Yeah, climate change, it has been declared as the greatest public health, the greatest public health threat that we have.
Wow.
WHO made that declaration during the COVID pandemic. That will tell you the magnitude to which climate change will be affecting health. Now, it's really challenging for us, particularly as American ophthalmologists, to really connect those dots. Again, climate change for me means I'm xeriscaping my lawn, and I need to use a whole lot less water because that's the climate change narrative where I'm living. If you're on the coasts, that's a different climate change narrative. We were just in Washington, D.C. for the Mid-Year Forum, and there is a cherry tree, a cherry blossom tree there, and it's called Stumpy. And Stumpy has become emblematic of climate change because they're having now to essentially remove 150 of these cherry blossoms, which of course are very meaningful to the people. And it's simply because there are rising sea levels. And wherever you live, you're going to have your own climate change narrative. Our climate change narrative might be moving trees, it might be xeriscaping lawns, but climate change narrative for people with low resources who already don't have access to eye health, that's a totally different equation. And again, when you're worried about where you'll live and how you'll eat, eye health becomes, of course, the last concern. And that's really our opportunity to, again, affect millions and millions of lives, whereas doing a cataract surgery overseas will affect the number of patients you're able to do surgery on. This is a way that we can really all come together and have a more dramatic impact on improving eye health through a way that wouldn't necessarily be intuitive.
I appreciate the interesting aspects of just the supply chain. You talk about just where vulnerabilities are, but I was recently at an international meeting and the comment was made over access to a medication like cyclopentolate or an antibiotic. And the comment was made that there's such difficulty in our practice in the United States getting a certain drug. And it was shared in an international location that in the United States, if you sneeze, the rest of us get a cold. And the aspect of you think your medication problem is a problem for you, and yet the United States still largely receives more of the available drug or more of the available instrumentation than places that normally have access to that drug and can't. So it was sort of this, not only the vulnerabilities of climate change and access and challenges and migrations, but it's even the simple fact of where the products are delivered change based on availability, and sustainability here directly impacts the access for these products around the world.
So yeah, really well said. Yeah, economics 101, the answer to all questions is money. You just have to figure out how. And again, where we will be paying more for medications with our system. They'll be made available. The good news is there's a lot that we can do to make a real difference. Again, everyone should go to eyesustain.org, take the pledge, educate yourself. The Academy is also for young ophthalmologists, for those in training, or within 5 years of practice. They've also created green grants. So these are $1,000 grants. These are meant to allow someone to start a project, whether it's a quality improvement project in your practice or whether it's a more of a research aligned practice. Andrea, in your world, there's Dr. Moody. She's the Ace Uppers Fellow down at Baylor right now.
Phenomenal.
She was, again, doing an assessment of their waste and their waste produced, looking at things like a DCR. So why is it that ENT would do procedures in office, whereas a DCR could technically be considered the same type of procedure? And why is it that we need to do these things in the operating room the way that we're doing them? And again, I really liked your comment. We in many ways, we determine a lot of what happens in the world just because of the nature of how powerful the American economy is. But this is an area, again, where we have an opportunity to learn from other countries. We have an opportunity to learn from other specialties. And as we move forward, we really need people to do these quality improvement projects or research projects, because until we have data where we can go to CMS and say, you created a regulation and stating that after 30 days, we need to throw away our drops, and you are basing that off of IV medications, those two are not equivalent. They might know that intuitively, but regulatory bodies' jobs are to protect patients. So they're going to be really conservative. They're not going to be aggressive at all. They don't want to get in trouble. So we need that data, and we need these projects to really show, no, this does not apply. And of course, until the expiration date, we can continue using these drops. And that was a big win. Multi-use drops. We use multi-use drops in our operating room settings, and we give a patient a drop in the emergency room. We give them a drop because they need it at that moment. But for many years, we haven't been able to send that drop home with them. It has to be thrown away. And so this is something going state by state right now, where you can find on the Academy's website some information where you can present through your state society a new rule, or if needed, or even a new law that allows for multi-use drops to go home with patients when they've been used on that patient, and otherwise they're mandated to be thrown away at this point. So the opportunities are really myriad. It's really a matter of what's your low-lying fruit that you can do right now. Everyone can go to iSustain, everyone can take the pledge, everyone can reevaluate their surgical packs, commit to produce less waste. And there are a few of you out there that can really dig in with one of these research projects, QI projects, that can help the rest of us and really magnify the scale of impact through your work.
We've been looking at this here at Mayo. It's one of these interesting things that trying to frame the research around evidence that moves the dial, because it's one thing to say, let's do a survey and survey everyone in ASCRS or whatever it might be to say, how often have you had an infection using, in the past when you could use a bottle and multi-use versus now where you're not able to, and it's hard to generate the research behind the quality projects to show safety when institutions have said, no, you have to do it this way now. Mm-hmm. It'd be nice to randomize two different centers, and in Utah, you use bottles for until they expire, or use bottles until for 30 days. Where maybe in Minnesota we get bottles reused or a new bottle for every patient and compare it over time. Mm-hmm. But I think the challenge in moving the dial is proving safety in a setting where we're asked to be overly conservative.
Yeah, well said. We've had that same experience, and interestingly, ASC's private practices, they're able to be much more nimble for a variety of reasons than some of the large institutions, where again you might think traditionally this is where we generate this type of data information. So again, it's interesting that in this particular case, so much of what we're going to be able to glean and learn are done at these high quality, high efficiency, high volume centers around the world. An interesting thing that happened in Erevant during COVID is they increased the amount of PPE. So they stopped having two patients in the room at the same time. They stopped having the patients stay in their own clothes. They started changing gloves each time. They started changing their gowns each time for each surgery. And nothing changed in terms of infection rates over a high number of patients. Mm-hmm. So again, we can see that when it comes to simply infection rates, and we should do anything and everything we can to avoid infection, avoid TAS, but we're so far on the one side of the spectrum, based largely on the fact that we're surgeons, and most of the regulations come from surgery inside the body, from general surgery or neurosurgery. And it turns out we are, again, ophthalmology is different in lots of ways. And this is an area where, again, particularly with cataract surgery, where we flush out so much during cataract surgery already, the key parts to infection control or concerns about cross-contamination between patients, those really seem to be much less of a concern than we would have previously thought. And now we just need the data to make some changes.
Yeah, I am optimistic about what you mentioned, that I think a lot of the power here actually is going to come from small scale, independent ophthalmologists at ASCs, and not necessarily the big academic institutions where we find a lot of regulatory pushback. And so the power is really in the community, which I love. We've tried a lot of initiatives here at Mayo. We've made a lot of good progress with the drop expiration dates. We're working on multi-use. Our residents did a quality project last year looking at the length of drapes for cataract surgery and trialed shorter drapes, which actually made a huge difference in the overall volume of waste. So little things like that, but the barriers and the work and the bureaucracy needed to make these tiny little changes is unbelievable.
It's fatiguing, yeah.
It is, for sure. So it's exciting to me that the power might be more in our community ophthalmologists who are able to make these changes without having to bear the burden of so much bureaucratic regulation.
Yeah, you're right. You're right on a number of levels, Andrea. And one is simply the number of private practice ophthalmologists compared to the number of ophthalmologists working in these larger hospital settings. The impact comes from and through the community. That we have to scale this impact to everyone. Neither you nor I nor any individual is really going to be able to make changes that impact everyone globally on our own. That's just, of course, that makes sense. We know that, we understand that. I like to think of it a little bit in terms of if I take a week and I go do surgery in another country and I am highly effective, highly efficient, and I do 250 patients that week. And that's the extent of my impact. That's lovely. That's beautiful. And those patients now have sight. However, if that's the extent of my impact and that's all that I can do over time, it only starts to change communities, change cultures, change countries if you have hundreds of people doing that. And of course, that's not an option. The way that you really gain impact globally is through capacity building, through teaching surgery, through skills exchange, skills transfer. And over time, as there are more ophthalmologists and you support a residency training program because you're an academic institution, or a private practice ophthalmologist hosts someone at their institution, that's the kind of 365 type of impact that really starts to change things. And again, sustainability is the same thing. It takes all of us doing small things as opposed to one or two of us doing something really heroic.
We had a previous speaker on global ophthalmology, multiple actually, that talked about that relationship building, education, skill transfer, pollinating each other's practices being more important than the number of surgeries you do when you land in another institution. But so it's about the relationships and about moving the dial together as a team. Talk to us a little bit about advocacy. So, in state academies, I think are such a critical relationship for ophthalmologists to be engaged with, to have a voice, to collectively look at these issues on a state level and also on a national level. But share with us just a plug, an encouragement. Andrea and I are both on the board for the Minnesota Academy of Ophthalmology, but just share, so we can wave that flag, but from an advocacy perspective and really trying to make a change through relationships, what would you share to individuals that haven't gone to a academy meeting or haven't been engaged with their academy and how important it is in this space?
We're only as powerful as our collective voice. And if you want an example of how that's the case, in an unrelated world, when you look at physician reimbursements over time compared to inflation, or you look at hospital reimbursements over time compared to inflation, whoever has the strongest voice, the best organized voice, and in this case, the most well-funded voice, those are the groups that are going to be listened to. And it's the same thing. If we really need or want our representatives to listen, our regulatory bodies to listen, we're only as strong as the community together. The Academy, is really fortunate, and because it has such a high percentage of memberships of ophthalmologists, the state societies, unfortunately, it doesn't always translate there. If you want to get something accomplished at your state level, and you have 90% of ophthalmologists who are members of your state society, that carries a significant amount of weight with our state representatives and legislators. And that's where a big impact can come from. You might be able to individually do something in your practice, but if you can make it so every ophthalmologist in Minnesota can now send that multi-use bottle home, that every ophthalmologist in Minnesota, and think of the cost savings to your practice, that you don't have to throw away a drop after 30 days of opening it. You can continue to use that all the way until it's expired. That alone is having a significant impact. And when you magnify that across your state, that's where you really have the impact that you're looking for. Because we all have that moment where we just finished a can of soda and we're looking for the recycle bin somewhere in the room and we don't see it. And we know that, it's probably not going to make that big of a difference if I just put this in the trash because there isn't a recycle bin. The individual impact can be relatively small at times, but it's really the collective impact of all of us coming together through advocacy that will have the greatest impact on our patients.
Really fantastic. I'm so optimistic and reassured about the future. Sometimes talking about climate change can seem like a really doom and gloom discussion, but I think the initiatives here and your passion and your leadership are really inspiring. So thank you, Jeff. This is tremendous work. I'm excited for everybody listening to this podcast to hear about iSustain and the initiatives that they can take part of, because really, like you said, this is for everyone. This is at a community level. It's not just for big, high, powerful institutions. This is for everyone, and the individual change seems small, but it can build. So thank you so much for sharing your work with us. Congratulations on everything you've accomplished, and we'll all keep working hard towards the goal.
You're so welcome. Thank you for having me. And you hit the nail on the head. This is something that all of us coming together can make a difference. And it's actually an area in particular that if you take a 46-year-old ophthalmologist and a 31-year-old resident, the 31-year-old can probably teach the 46-year-old a whole lot about climate change and about impact and how we can do this better. So this is something where my optimism simply comes from the energy and the knowledge and the excitement and the motivation from our young ophthalmologists. In this case, they are leading the way, and they will lead the way in the future.
Wonderful.
Yeah, and wonderful to have you be part of our podcast. And for all the listeners, as you click off this podcast, go and click on iSustain and learn more. But thank you for being with us today.
Thank you, Jeff.
You're welcome. Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology podcast on our website.
Thank you for listening, and we definitely look forward to sharing more